Well, hi there, and a very happy Tuesday evening to you. I'm Dr. Randy Fink, and this is Fertility with Fink. We are here every Tuesday evening at this time, 5 o'clock Central Time, which means 4 o'clock in the mountains, 3 o'clock on the West Coast, and 6 on the East. I am live from Pensacola, Florida, where I am a fertility gynecologist here at New Life Fertility. And every week at this time, we join in to talk about all those things that are most important in terms of making your family and getting where we need to be for our happiness. It's a scientific process, it's a medical process, but it's also, as we know, a very emotional process. And what do? We come here together to talk about all those things that are important and join in to see what kind of community we have because we all share in this same roller coaster ride. So glad to see everybody. We've got some different feeds here as we always do on Tuesday. I've got YouTube and Facebook and LinkedIn over here. We've got a couple of different Instagram feeds. Here's mine, Randy Fink MD, along with New Life Fertility's Instagram feed. Let's say hi to all those folks who are joining us here. Hi to Kowser. You are number one on my list tonight. Thank you for being here, the very first one to join. Hey to Emily, Rosa SD, thank you for being here. The Styles family, thank you. Who knows Crystal? I know Crystal. And Haley, looks like Haley is here. Rosa, it's my pleasure to be here with you. I am Old Soul, Rosa Johnson. Jill, Angela is here. Hello, Angela. Shaylin, Nurtured Shanna, as always, thank you for being here. Hi, Sharmilla. Good to see you. Hope you're feeling well. Shaylin is here. Shaylin asks, I got pregnant last year and had babies early at 27 weeks. If I wanted another baby, is it likely that same sort of thing would happen again? So what we're talking about there is the risk of repeating preterm labor. Why does preterm labor happen? Well, the truth is nobody really knows the answer to that. There is some belief that there may be some factor of either an overt clinical infection inside the uterus or a subclinical infection, some sort of inflammation that ultimately causes the onset of labor. Some folks have believed that it is a shortage of progesterone that causes preterm labor. And so for a long time, we were giving extra progesterone to folks who had a history of preterm labor. But as it turns out, it didn't really make a whole lot of difference. Preterm labor is one of those things that we have really not been able to get a great handle on. The only thing we know of that has been shown to prevent a severe preterm delivery is a short, or well, I should say the only thing that's been known to cause that we can prevent a severe preterm delivery is that short interconceptual interval. That is someone who has a baby and then within a few months goes to have a baby again. They say that the ideal length of time between children is between 1 and 5 years. So if you conceive before 1 year, but you have the baby within that year, then that is said to be enough. So I usually recommend folks wait about 9 months after having a baby before trying to get pregnant again. That's usually my thought there. Having had a preterm delivery, Shaylin, does increase your risk for having another preterm delivery. So what would you do about that? Well, you'd be followed very closely by your OB in order to make sure that we're not seeing your cervix starting to get shorter ahead of time, because if we saw the cervix starting to shorten, you would probably be given a dose of steroids. The steroid is something that's called betamethasone, and the reason we use that is because it speeds up the baby's lung maturity. Because the principal problem that babies have on the outside is the inability to really know how to breathe air. You know, the baby on the inside is getting oxygen not from the air like we do with our regular kind of circulation, but the baby is getting oxygenated blood that's traveling through the placenta, through the umbilical cord. And so it takes some time for the lungs to be able to mature. And that's one of the biggest problems babies have on the outside, is that lung maturity. So when we give steroids, it is designed to accelerate the lung maturity so that hopefully, if the baby is born early, they will be more readily able to breathe on the outside without having to worry so much about ventilators and that kind of thing. So yes, Shaylin, you are at an increased risk, but having had it happen one time means you'd be followed very closely. And I wouldn't say that it's any kind of guarantee that you would have another preterm delivery. It certainly isn't. It's possible, but not definitive. Sean Lift says, my day 6 PGT embryos always implant late, low betas, and my receptiva test said 120 hours, but isn't that only for 5-day embryos? Do day 6 embryos need one more day of progesterone, or is it treated the same as day 5? So when you said receptiva is actually a test that's used for endometriosis. I think you mean an endometrial receptivity assay, or an ERA. I will say that the ERA has kind of really fallen out of favor. The data on the ERA has not really shown it to be all that useful. Yeah, you got it. You know what I meant. But the answer there is no. It doesn't change things. So you have a day 6 embryo. And basically what that means is that, well, so normally a blastocyst typically happens by day 5, but sometimes it does take a little bit longer. So that means that it took 6 days for it to become a day 5 embryo. Does that make sense? And so just because it's day 6 doesn't mean that you need an extra day of progesterone before you do your transfer. It became a blast at day 6, but a blast is usually day 5. So it took 6 days to become a day 5 embryo. Or if you have a day 7 embryo, it means it took 7 days to become a day 5 embryo. The difference between a day 5 and a day 6 blastocyst is usually not very much in terms of the way that embryo performs when it's inside your body. A day 7 embryo doesn't perform as well as a day 5 or a day 6. But if you've done PGT testing and you know that you have a euploid embryo trumps everything, whether it's day 5, day 6, or day 7. But to answer your question, nope, the standard is 120 hours of progesterone unless there is some reason to believe that you need to have something different, or if the test shows that you did. Now, we used to recommend that folks routinely do that endometrial receptivity assay. And as I say, that has really fallen out of favor because the evidence has shown, well, it really doesn't make all that much difference. Most people, if they are not 120 hours, are going to be a little later than that, and then it truly doesn't make a difference in terms of outcomes of positive pregnancy tests or live births. So hopefully that answers you there, Sean Liv. Thank you so much for being here with us tonight. Are tears unavoidable at natural delivery for first-time moms? Is there any tips to reduce the chance of them occurring? And that comes from Rosa. And it's a great question. We're talking about tears of the vaginal wall, usually around the opening. So sometimes an obstetrician or a delivery attendant will make a cut, and that's called an episiotomy, in order to affect the delivery of the baby. So when I was doing OB, the only times that I would cut an episiotomy were really if we had to expedite the baby getting out, like the head was right there, it just wasn't coming, but the heart rate was dropping, and I knew it was time to get the baby out, and the only thing that was holding it back was a little bit of skin. That's really the time. Or if it truly looked like that skin, that whole area, what we call the perineum, was about to kind of explode. And the thinking is that we would rather have a controlled tear, something that we can have nice clean edges on that can be easily repaired instead of a jagged and ragged tear. The truth is, well, maybe that's true. Maybe it's not. In most cases, a perineum or a vaginal opening that hasn't previously been stretched by a baby coming out has a tendency to want to tear. It doesn't always happen. It certainly doesn't always happen. Many midwives will promote what we call perineal massage leading up to the time of delivery. And that's where you naturally, with your fingers, do some stretching around the opening of the vagina uh, so that it may be more apt to naturally accept that head without tearing. I have not seen any evidence that shows that that truly makes a difference and prevents a tear from occurring. But a careful birth attendant will do everything that we can in order to minimize the tearing that occurs with childbirth. Nevertheless, it is not uncommon to have some tear there, and that's usually something, in most cases, that's very easily repaired. So, not something I want you to worry about. Um, I do want to mention one thing since we're talking about pregnancy care while we're on the subject before we kind of move back to fertility care. And that is many people talk about having a birth plan. And I just want to give my 2 cents worth on the birth plan. I believe that you can prepare for labor, but you really can't plan labor. You have to be very fluid and very able to kind of roll with the punches because we really can't control it. It's going to do what it's going to do. That baby is going to do what it wants to do, and your body is going to respond the way it wants to. And there are too many factors that are out of anyone's control. So, an attempt to control things by creating a birth plan in my view is really bad luck. So when I was practicing OB, I would be happy to talk until we're blue in the face about all those things that are important to people. When I practiced, I would say you don't have to have an epidural unless you want one, and if you want one, you're welcome to it. You don't have to be connected to an IV. We have to have IV access in case we need it, but you don't have to have an IV. We would not use Pitocin unless we absolutely had to, because if not, the only reason is if your labor stops. And dad gets to cut the umbilical cord. We do delayed cord clamping. We would only do a C-section if the baby was really at risk or labor really stopped and we couldn't get it to progress. Those are the kinds of things that are really most important to people, I think, in labor. But sometimes folks want to create a list of rules that they demand be followed. I wouldn't do that because really what's most important is the safety of the baby. We want it to be your delivery experience. Obviously, as an obstetrician, would want your delivery experience to be exactly what you would want it to be. I don't want it to be anything but the dream delivery that you're hoping for. But you just can't make rules about those sorts of things, because what's going to happen is going to happen at the time of delivery. And you have to be willing to kind of, as I say, roll with the punches. I kind of feel like it is bad luck to have a very detailed birth plan. It's important to discuss these things with your provider so that everybody's on the same page. That's very important. But to have a detailed list of rules that you insist on being followed, in my opinion, is a ticket to the operating room, because the more rules you have, the more disappointed you're going to be at the time of delivery, because you just can't have everything the way you want it. Why? Because it's out of our control. I can't say what the baby is going to do or not do. And at the end of the day, it's all about your safety and about taking home a healthy baby. So I'd say be fluid about it. Have these conversations with your provider, but don't be married to a set of rules, because the more rules you want to have followed, the less likely you're going to get everything that you want. Hopefully that makes some sense. Hi, M. Roth, and hi, there is a plan. Nice to see you as well. Angela said, I figured out how to change my profile name. Oh, good. So now you're now you're Angela instead of whatever that thing was before that I couldn't pronounce, but at least I knew who you were. Nurtured Shanna is a wonderful soul, and I'm so honored to have you here on my program tonight. Shanna says, is it true that HCG rises slowly after 2000? Mine rose from 2271 to 4874 over 4 days, which is slower than it has been rising so far. I'm currently 7 weeks pregnant. So we do know that the beta HCG will double in 2/3 of normal pregnancies. So we look for that doubling of the HCG to be reassured that we're not dealing with an ectopic pregnancy, or a pregnancy that's not inside the uterus. Once you have seen the pregnancy inside the uterus, and when you look, and if you saw my post the other day, when you look and see a heartbeat, we know that 95% of those pregnancies will continue on without having a problem. So the most important kind of number there is really 1,500 to 2,000. And that's what we call the discriminatory zone. And when you are at or beyond 1,500 to 2,000, we should be able to diagnose an intrauterine pregnancy by transvaginal ultrasound. So you should be able to have an ultrasound vaginally, and we should be able to see that the pregnancy is inside the uterus. So that's really the most important feature. And typically we're looking for that beta to be doubling in the time before that. Once you look with the ultrasound and you see the pregnancy in the uterus, really the doubling of the beta is no longer relevant, because it is not necessarily predictive of viability of the pregnancy. That is to say, it is not predictive to say, oh, well, how is the pregnancy growing? Doesn't mean anything in that regard. Really, it's about, is it growing and is it going to be inside the uterus? And once you look and see that it's in the uterus, no longer really is that doubling beta considered to be predictive. And in my opinion, I wouldn't keep doing the betas at that point, because as long as they're going up and you've seen a heartbeat, then you know you're going in the right direction, Shannon. So fingers crossed there, my friend. Thanks again for being here. Sharmila is doing great at 33 weeks. And oh my heavens, you know, Sharmila, I remember the days. I remember the days, as I am sure you do. And you know, that's an important consideration, because the whole thing that we have to go through here to get pregnant, especially if you have to do fertility treatment, is really a bear. It is that emotional roller coaster that's truly, truly hard to ride. And it's resplendent with pain. Think about that rough roller coaster. It jams you this way, you hurt your neck. It throws you that way, you get a little concussion from it. You're nauseated. It's blowing hot air in your face. And oh, wow, it just really doesn't feel good. Sometimes a roller coaster is fun, but sometimes it's not. And this is one of those times that oftentimes it's not. But then once you are pregnant, all that pain suddenly seems, wow, just so far away, doesn't it? It seems so distant from the reality that now you are gonna have that baby. Now you're getting the nursery ready. Now your family's getting prepared, and all those dreams that you hope for are suddenly within your reach. It really seems that that all that pain kind of becomes relative. And I think honestly that's one of the reasons that we do it again. You would think that folks who have a vaginal delivery, for instance, and don't have anesthesia, you would think that would be probably one of the best methods of birth control imaginable, because the kind of pain that's associated with that delivery is unlike anything most people have ever experienced before. But yet, You hold that baby and you look at that baby, and suddenly people are like, wow, all that pain very quickly is forgotten. There's an endorphin high that comes along with that. It's like the runner's high. Um, and and very quickly, the pain of labor, you may remember it, but the human mind doesn't have a great capacity for really remembering what pain is like. And that's why people go back and have babies again. So really, it's a fascinating thing. I was tested positive for MTHFR. Would methylfolate and Lovenox help? So that's another very good question. The MTHFR gene stands for methylene tetrahydrofolate reductase. And I just like to say that because it makes me sound really intelligent. Methylene, well, your methylene tetrahydrofolate reductase is, it's actually your C677T variant. It's a very common gene abnormality to have the MTHFR mutation. And we used to think that it had something to do with recurrent pregnancy loss and recurrent miscarriage and things like placental abruptions and blood clots and things like that. What we know now is that it is not associated with routine clotting problems. What MTHFR is a gene that encodes the metabolism of folic acid and one of its byproducts, which is called homocysteine. There are situations in the human body where your homocysteine level can be high. And if your homocysteine is high, then it may increase your risk for certain types of clotting problems. But just because your MTHFR mutation says you don't metabolize folic acid properly doesn't mean that your homocysteine will be high. So now we really don't test for it anymore. It is no longer considered to be a relevant test. It really doesn't mean much of anything. So I don't encourage people to test it. However, what we used to believe is that if you had an issue with your MTHFR gene, then you needed a special type of folic acid, and that was something that was called methylated folate. And so that's what you're talking about there. Would methylfolate be helpful? And I would say, sure, absolutely. In my opinion, I think methylfolate is a great way to get folic acid for everybody. But what we really know now is that for the vast majority of the population, even regular folic acid is plenty fine, no matter if you have that MTHFR mutation or not. The Lovenox part, in your case, Angela, there is really unnecessary because the MTHFR gene does not confer an increased risk for clotting. So using Lovenox is really something extra. Call it icing on your cake. Is it hurting anything? Probably not, but is it helping? No, it is not, at least with regard to the MTHFR situation. And I say, is it hurting anything? And, it doesn't feel good to get the shot. It stings, right? And it can create all these bruises on your belly. And it's all well and good until you fall and hit your head when you're on a blood thinner. And then you end up with some kind of bruise on your brain. And then, yeah, it actually did hurt you. So it's not a benign medication. It's not a benign drug. And so if you don't need blood thinner like Lovenox, I suggest that you not actually be on it. Erica Ann asks, is there any data when is best to start blood thinners around FET with recurrent pregnancy loss? I'm also starting 2 days. I'm always starting 2 days after the FET, but wonder if it is worth it to start beforehand. Well, so there's some different data on that, Erica. You have a situation with recurrent pregnancy loss. So something is causing your pregnancies to end prematurely. What is that something? Well, we don't always know, but there are a series of tests that we can do to see if there's something in your blood that's causing what we know as a thrombophilia. Thrombo means clot, philia means likes to. So is there something in your blood that likes to clot? Um, some of these things are hereditary, some of them are acquired, they just kind of happen. They are often associated with family histories of things like blood clots in the leg, or maybe you had a blood clot in your leg when you were on birth control, or a blood clot that travels to the lungs, a deep vein blood clot, or what we call a DVT. If you are known to have a thrombophilia, then using Lobinox, typically I would start it, yes, before you do your embryo transfer, usually, or at least at the time of embryo transfer, usually a day or two before. There are some programs that recommend you start that Lobinox actually in the beginning of your cycle when you're just starting on your estrogen, if you're doing a medicated cycle. So if you're known to have one of those clotting issues, then yep, absolutely, Lobinox is going to be helpful. If you are not known to have one of those problems, there are some programs that will preemptively just treat you with Lobinox. And I think, even though the guidelines from the American Society of Reproductive Medicine say don't do that, to me, I think it's not an unreasonable idea, just because there are lots of things that we don't know. We are always learning something, and it may be something about you. It may be something about your pregnancy, something about your body, or about your ability to maintain that pregnancy. So there are certain circumstances where I feel like treating people with these medications may actually be useful, even if we don't for sure know that it's going to be helpful. But to answer your question, I usually do start it prior to the embryo transfer as opposed to a couple of days afterwards. What would be the rationale for starting it a couple of days afterwards? Well, you're doing your embryo transfer, but it's still going to take a little time for that embryo to implant inside the uterus, probably on the order of a couple of days. And so by the time you're starting your blood thinner, that's about the time that the embryo is really starting to grow inside that endometrium. To me, it's nice to have it a little bit beforehand, but again, the shot doesn't feel good. It can make you bruise. It stings when you get it, and it can cause you problems, especially if you suffer with something like a fall. So hopefully that's helpful there for you, Erica, and best of luck with that recurrent pregnancy loss thing, because it's a real challenge to deal with. Hi to Ashley and Angela over here, who have joined us on New Life's Fertility. And if you're just joining in, we're about halfway through the program. This is Fertility with Fink. My name is Dr. Randy Fink, and I am a fertility gynecologist at New Life Fertility here in Pensacola, Florida. We have offices in Dothan, Alabama, and Panama City and Tallahassee. We get around and we see people from all over the country. I am happy to see you for your fertility concerns or for your embryo transfer, especially, you know what, gosh, if I met you before and I was involved in your care, I am happy to see you here, or even to just consult with you and do everything I can to help you see that joyous day when you become pregnant. Asking for my sister, 41 and single. She froze her eggs from 3 rounds. She got 25 eggs. No endometriosis, no diseases. How many of these 25 eggs will be genetically normal? Well, at 41 years old, so actually, I will tell you, there is a calculator that we can use that will tell us, and gosh, you know what? All my devices are in use now for this broadcast. So let me tell you what the calculator is. If you go to MD Calc, that's MDCALC, Google MD Calc egg freezing calculator, or MD Calc egg freezing. That will bring you to a page where you can put in the person's age and the number of eggs, and it will tell you the approximate percentage of probability that you will get 1 live birth from those eggs, 2 live births from those eggs, or even 3 live births from those 25 eggs. And I can't go and do it here because, like I say, all my devices are in use. But punch it up there, and it'll tell you what's the probability that she's going to have a birth from those, which basically means what's the likelihood that those eggs are going to be chromosomally normal. So at 41, it's probably on the order of about 10% of her eggs would I expect to be 10 to 20% what I expect to be chromosomally normal. But then you go through the process of fertilizing those eggs and everything else in the lab. It actually does give you a meaningful number. So that calculator I use to help counsel people to say, well, how many eggs do you really need in order to feel comfortable that you're going to get a baby from this whole endeavor? Because when you're doing egg freezing, which I think is something we really ought to be talking about more, um, egg freezing as an endeavor, as a science now, is something that's really very effective. We've come a very long way in being able to cryopreserve eggs, to freeze those eggs. And the younger you are when you get those eggs, the greater the probability those eggs will be useful to you sometime later in life. Now, does that mean that let's say that you decide that you're going to freeze eggs at 25? Does that mean that you ever have to use those eggs? No, absolutely not. It's an insurance policy is basically what it is. It is quite literally a fertility insurance policy. And that is to say, you can still 100% get pregnant in the normal way, but at least you have the option to use those eggs that came from you at a younger age. So let's say that, well, you save the eggs at 15, but gosh, by the time you turn 39 or 40, you still haven't found the right person yet that you want to have a baby with. Well, you've got eggs that came from you at 25, which would be highly probable to be mostly normal and be able to get you a baby, even if you weren't able to do it at 40, 41, 42. I think that's great, Rosa, that she got 25 eggs at 41. That speaks to a very good ovarian reserve for her. And so hopefully that will all prove to be useful stuff. Hey to Hairs Lee, I think is what that says. Went to Dr. Rips and successfully pregnant. I'm so happy to hear that. That's great news. Shaylin's talking about her delivery that happened at 27 weeks. I don't know what happened. Everything was fine. My cervix was completely closed. I'm very allergic to latex. They did use a latex condom. The same day with another ultrasound, my cervix was completely open. So, gosh, hard to know what to say about that. But certainly, if you're highly allergic to latex, don't use latex condoms. Important consideration. Yeah, indeed. Hi to Nick Batez, positive HCG today. Congratulations. Awesome. Should I continue on the immune protocol, the CoQ10, the L-arginine, and the lipoic acid? So I would say no. With a positive pregnancy test, really all you need is your prenatal vitamin, and I would recommend fish oil or omega-3. As far as the immune protocol, usually you stay on that stuff until you are directed to go off of it, which typically is going to be, excuse me for yawning. You know what? I was just starting to say, if you're taking progesterone, sometimes that may help you to sleep. And I started to think that, and that made me yawn. Boy, that's embarrassing. You may... usually, so progesterone typically continues to 9 or 10 weeks because at that point your placenta takes over for making the extra progesterone. And as far as the other things, you'll want to taper off the prednisone. That's usually around 10 weeks or so, and it's a taper. You don't just want to stop cold turkey. So wait for the direction on when to stop. But as far as the supplements go, prenatal and omega-3 are really the only things you need. As far as the other ones, you're done with them. Congratulations, Nick. Boy, that is great news. Let's see. Haley J. O'Rourke says, I have had 2 healthy pregnancies and I got pregnant easily. Now I've had 4 consecutive early miscarriages, one of which was our only PGTA normal embryo. Well, so, that makes me wonder what else is going on in your body. certainly makes me wonder about things like scar tissue in the uterus. So I would want to be looking inside your uterus. That's called a hysteroscopy. Hystero means uterus, scope is to look inside. A hysteroscopy to make sure that there is no scar tissue or polyps or bands of muscle or something on the inside of the cavity that is creating a challenge for your embryos to be able to implant. Additionally, I would start thinking about things like, well, have you developed endometriosis? Because that can be a cause. Is there something like chronic uh, endometritis or a chronic inflammation in the lining of the uterus that may be preventing an embryo from implanting? So certainly I'd say, Haley, there's a bunch of stones to look under there because, yes, something's not right in that scenario. So I would think we'd really want to help you with that. Kristen says, I also saw Dr. Rips and my daughter is 14 months old. 14 months old. That's fantastic. Love to hear that. We went from 33 eggs to only 3 embryos that made it to the end. The first transfer didn't take. The second transfer, we transferred the remaining 2 embryos, and we have my daughter. That is the kind of story we like to hear, Kristen. Congratulations, and enjoy that beautiful baby. Oh my gosh, you're making me yawn again. So I was actually, every time I start thinking about sleep, so you're talking about a 14-month-old. I was going to say a 14-year-old, you probably don't sleep very well then either, wondering what she's doing. But I hope you are sleeping well by now with a 14-month-old. See, and that made me yawn again. So clearly I am not getting enough sleep. April asks, is there a difference between letrozole and menopur protocol for an FET and the estrase and progesterone protocol? I've always been on letrozole and menopur, wondering if switching can give better outcomes. Well, they are, trying to affect the same thing there, April, but they do, but they get about it in a very different way. So what are they doing there? So with the estrase and progesterone cycle, that's what we call a programmed cycle or a medicated cycle. And what's happening there is that we are giving you all the hormone that your body needs. And while we're doing that, we are suppressing your body's ability to make that hormone on its own because it doesn't need to. We want to be in control of every variable with a medicated cycle. So we give you the estrogen to thicken up the lining and make it a nice, spongy, warm, juicy place for an embryo to implant. And then we give you the 6.5 days or 120 hours of progesterone to make that lining compacted and ready to receive a pregnancy. So that's what the medicated cycle is with the estrogen and the progesterone. The other option there is some letrozole and menopur. And what you're doing in that scenario is ovulation induction. You are asking your brain to tell your ovaries to make a follicle, to grow that follicle or 2, and to release those eggs on your own. Because when you grow those follicles, you are making your own estrogen. And when you release that that egg and you ovulate, you start making your own progesterone. So in a natural cycle, or in this case, that's a type of what we call a modified natural cycle, you're making your own estrogen and progesterone by producing that follicle in your ovaries by doing ovulation induction. So they're 2 different things, but the data tells us that they are at least equivalent. There are some studies that suggest that the natural cycle or the modified natural cycle may have a little higher pregnancy rate, may have a little lower miscarriage rate, and certainly does, we know, have a lower risk for certain types of pregnancy complications, specifically things like blood pressure complications that happen later in the pregnancy. But in the United States, probably 75 to 80% of the cycles that are done for frozen embryo transfer are medicated cycles, because that's the way things were always done. It's what we call medical inertia. That's the way things started. And so that's the thing that there is the most experience with, the most evidence behind. And people just kind of still stick with this notion that if we can control every ounce of hormone that's going on in you, then maybe we'll do better with that. Is that the truth? Well, I don't think the evidence shows that it's necessarily better, but we would say that those two things are at least equivalent. So that's the difference. Thanks, April, for that question. Kristen also said, "Yep, and she is a wonderful sleeper, thank the Lord." So, a couple things that makes me want to mention here. That whole idea, and I am no expert on babies sleeping. I have 3 kids of my own now, 18, 17, and 13. So it's been a long time since we had to deal with babies sleeping, but that is a very frustrating problem, to get your baby to sleep all night. There is a book, and it is still something that is widely renowned, called The Sleep Easy Solution. And it's a difficult thing to do, because in a lot of cases, you just have to let them cry it out. And nobody likes to hear their baby cry, especially not all night. It's torture. It pulls your heart out of your chest and slams it against the wall. You hate to hear your baby cry and be upset. But as you know, in many cases, they just want comforting. They want comforting, and they in theory need to be taught to self-soothe, especially at night. Again, I am no expert at that, but it's a very real concern. And Kristen, I am so happy that your baby is sleeping. Aren't you glad to have that behind you? New attitude. Hi, how are you? And let's see what else here. Oh, by the way, one other thing, Haley, that you mentioned, because we were talking about recurrent pregnancy loss. There's another avenue that we look at for pregnancy loss, recurrent pregnancy loss, and that is something having to do with sperm, specifically with DNA fragmentation in sperm. Because what is a sperm? It's a little packet of DNA with a motor on it, and we can see the head and the neck and the tail of that sperm, but we can't see the DNA. And sometimes there is an increase in the kind of the falling apart of that DNA. So a sperm DNA fragmentation test, I think, is something that's potentially meaningful in couples that are having issues with recurrent pregnancy loss. So just something to think about there. Hi to Maggie Michelle Bama Gal, my beautiful and wonderful mother in Mobile, Alabama, and dad, who are sitting there together not too far from me. You might have seen on my Instagram, I put up a nice little post that they celebrated their 65th wedding anniversary just the other day, and so proud of them. They are still as beautiful a couple as they were when they walked down the aisle. And I mean that with all sincerity. Hey to Runner Girl Training, nice to see you there. Angela Fox is with us from the great state of Minnesota. Let's see, Earth Girl Peace is here. Is a high-level mosaic segmental day 7 embryo worth transferring? The embryo was made when I was 42. Well, so what is a mosaic embryo? It is not an uncommon finding. A mosaic embryo is not a throwaway embryo. It does not mean that it's a bad embryo or that necessarily it's an abnormal embryo. If you remember that when we do PGT testing on an embryo, we are testing from the outside portion of the embryo, the part that will become the placenta. So we are not testing from the part that becomes the baby. We're not taking a piece of the baby. They're testing from the outside, the part that becomes the placenta. If you recall, also, there are 2 sets of chromosomes, right? We've got 23 pairs of chromosomes, or 46 chromosomes. A mosaic embryo is one in which one set of those chromosomes seems to be abnormal. Now, we don't really know what that truly means in the body, because you can have a situation where the body repairs that abnormal DNA, or you can have a situation where the placenta has mosaicism. It's called placental mosaicism, but the embryo itself is normal. So when we look at an embryo that has been biopsied and is known to be chromosomally normal, we know that that embryo has a 65% probability of giving you a pregnancy. At 42, an untested blast at 42 has about a 5% or so chance of giving you a normal pregnancy, whereas a mosaic embryo is anywhere between about a 20 and a 30% chance. So you've got a bunch of things that are, sound like they're going against that embryo. It's a segmental mosaic. It's a day 7 embryo, and that means it took 7 days to become a day 5 embryo, like we talked about before. But it still has a 20 to 30% chance of giving you a baby, as opposed to your untested blast that has about a 5% chance. So it is not a throwaway embryo. It's actually better than an untested blastocyst. If it is an abnormal embryo, then in all probability, it will not continue to grow. There is a higher risk of miscarriage with a mosaic embryo, but nature has a way of taking care of these embryos so that they don't grow. The odds of having a live birth with a chromosomally abnormal baby is extremely small when you do IVF, exactly for that reason, because those embryos typically just don't grow. Ermav is here. Hello to Florida Girl and Alexia. It's nice to see you up in the Carolinas there. Hi, Blaxican Beauty. Nice to see you as well. Mo, gosh, Miss Amal, I never know if it's Mohi or Mohai, so forgive me for mispronouncing your name, okay? What brand of CoQ10 do you recommend? Well, it's not so much a particular brand, but you ask an excellent question that I want everybody to know. Everybody who is trying to get pregnant should be on CoQ10. What kind of CoQ10? There are 2 forms of CoQ10. There is one that's called ubiquinol. 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 Ubiquinol is the form of CoQ10 that your body naturally uses. And when you are taking ubiquinol, you need 400 milligrams a day divided in a divided dose. So twice a day, 200 milligrams twice a day. But there is another form of CoQ10 that you can purchase, and that's in the ubiquinone form, and that's Ubiquinone, ubiquinone. Ubiquinone is what's called the oxidized form of CoQ10, and your body has to, which is fine. It just means that your body has to convert it in order to get it to work, and therefore you need a little higher dose of CoQ10. You need 600 milligrams in a divided dose, or 300 milligrams twice a day. So, Ms. Amal, it's not so much the brand as what type of CoQ10 you have. Ubiquinol is 200 milligrams twice a day for a total of 400 milligrams. Ubiquinone, just think none, N-O-N-E is how it ends, is the type that your body has to convert. And so you need 600 milligrams or 300 milligrams twice a day. Everybody trying to get pregnant should be on extra CoQ10, 400 milligrams of ubiquinol or 600 milligrams of ubiquinone divided into 2. If you get nothing else out of this whole evening, please remember that. How long after stopping methimazole would you recommend doing an FET? Well, so here is a question, and we talked about this. By the way, I will say this wonderful person emailed me through our email address. If you ask a question here tonight and we can't get to the answer in time, please feel free to email that to Ask Fertility with Fink at firstfertility.com. Again, that's Ask Fertility with Fink at firstfertility.com, and we will answer your question top of the show next time. But here was an issue of someone who has hyperthyroidism. Hyperthyroid. What does that mean? The thyroid is hyper. Its volume knob is turned up too high, so the thyroid is overworking. And that can be a very dangerous situation to your body. It's something that can be very dangerous for pregnancy. We do not want you to get pregnant when you are hyperthyroid or hypothyroid for that matter, because both of those can cause very serious consequences on a pregnancy, not to mention on your body. So one of the treatments for hyperthyroidism is a medication that's called methimazole. There is another medication that's called PTU, or propylthiouracil. Usually, for folks who are trying to get pregnant, we will use PTU in the beginning of the pregnancy because methimazole has been shown to cause birth defects. So methimazole is not something we want you on when you're trying to get pregnant. We usually use PTU in the beginning, and then once you're out of the first trimester, we change that over to methimazole because PTU in the long term can be toxic to you for other reasons, whereas methimazole is fine in pregnancy outside of the first trimester. So how long after stopping it? I would say probably about a month. I believe it has a fairly long, what we call half-life, which means it stays in your body for a little while. So my friend, I would recommend, kind of give it a full cycle. But it may be that your endocrinologist wishes to start you on PTU to keep your thyroid suppressed, although we did actually look at your thyroid numbers and they looked pretty good. So in fact, you look like you're probably starting to trend in the other direction. So I agree. Maybe it's time to stop that. Hi to Jackie Lee and Dancer. Nice to see you here tonight. Mrs. Vince in the beautiful state of Kentucky. Thank you so much for being here, as well as Mrs. Villarreal. Shushan, thank you. Emily Miha, thank you. Kauser says, with the thyroid disorder, can I take 600 milligrams of CoQ10 with soy lecithin 50 milligrams? Without soy, I'm not finding CoQ10 at 600 milligrams. So the soy lecithin is fine. You may want to look for it specifically as well, actually, if you want to send me something through Instagram, I can send you the ones that I recommend. But if you search for it in the health food area or online, you can look for it specifically as ubiquinol or ubiquinone. Ubiquinone is 600 milligrams. Ubiquinol is 400 milligrams. But yes, you can use it with the soy. The soy is metabolized as what's called a phytoestrogen. So yep, you'll be fine with that. Hey to Kat. Earth Girl Peace, is it possible to be pregnant with 0 symptoms during the 2-week wait after your embryo transfer? And I would say absolutely, friend. Yep. Even if your last prior successful transfer had a lot of symptoms, I am nervous. I will say you are 100% right to be nervous because that is the hardest time. That 2-week wait stinks, man. It's the worst having to wait. Some people get, pretty significant breast tenderness towards the end. Some people start to get a little nauseated. Some people just feel like their body is different. But having no symptoms is completely normal because the hormone levels at that point are still so very, very low that I wouldn't necessarily expect you to have symptoms. So yes, it's okay. Gosh, our fingers are crossed for you there, friend. Ain't no BB. Hi, doctor. Ain't NBB. I had my day 3 FET in June, on June the 4th. My progesterone was 52. and then 86. My estrogen was 588, then 888. Is the progesterone too high? I'm on PIO and endometrium. So the answer is no. There has never been anything that's shown us that there is a progesterone level that is considered too high. There absolutely is a progesterone level that is too low. But a progesterone level being too high is not something that you need to worry about, and your estradiol's there are fine as well. We don't really even need to look at the estradiol at that point, but you're getting plenty of progesterone, and that's what your pregnancy needs to continue on. So good deal. Let's see. Kat asks, can I have a successful transfer without prednisone? Yes. I have endometriosis, adenomyosis, and I am 41. Any alternatives? So there are some practices that routinely include prednisone or a steroid as part of what they consider an immune protocol. That is not a standard of care in the United States. That is that particular practice that does it that way. So can you do it without prednisone? Most places in the United States do it without prednisone. I would not expect prednisone to have really any significant effect on endometriosis or adenomyosis. So yes, you can do it without prednisone, and you do not necessarily need an alternative. Now, there may be some other reason that you're on it, but again, as a matter of routine, it is not something that most places actually use. Is that Jessica Steele? Nice to see you here if you're still on. Gosh, we got lots of friends joining here. Lexi asks, would you suggest a hysteroscopy or a saline sonogram for diagnostic testing? I had an HSG before. Well, yeah, so the HSG is really, it will show you the contour of the uterus, and it will show you that your fallopian tubes are open. However, an HSG is not sufficient to show you smaller pathology that can be inside the uterine cavity. Personally speaking, I like a hysteroscopy. In our practice, we want you to have a hysteroscopy at least once a year because you can develop problems inside the uterine cavity that take up valuable real estate that are going to keep your embryo from implanting. So a saline sonogram is a way to have it done that doesn't require a gynecologist because a radiologist can do that. And you can often do that really at any radiology type facility, whereas the hysteroscopy has to be done by a gynecologist. Now, sometimes that can be done at the time of your egg retrieval if you're doing IVF when you're already going to be under anesthesia. But if you're planning to do a fresh transfer, then you don't want to do that because you don't want to be touching that endometrium if we are going to be putting an embryo in there at that cycle. Oh gosh, folks, we are going to be running out of time here. There were a couple more questions that I couldn't get to. I am at Earth Girl Peace. Does anyone know which location Dr. Fink works at? I can say that. I'm at New Life Fertility, which is in Pensacola, Florida, and the website there is fertilityleaders.com, or simply send me a note through Instagram at RandyFinkMD, and I am happy to point you in the right direction. Make sure that we can get you an appointment. If I didn't get to your questions tonight, please, by all means, email those to me. Ask Fertility with Fink at firstfertility.com, and we will get to them at the top of the show next week. Folks, you know, this, as I always say, this whole business of fertility is not the story of your life. It ain't your novel. It is only a chapter. And what are we here to do? We are here to rewrite the damn thing together. So let's do that. Every step forward with kindness to people around us, every step forward with love, and every step forward with hope, knowing that tomorrow is a new day full of all new adventures. And I can't wait to be a part of your adventure. Thanks so much for being here this Tuesday evening. Dr. Randy Fink from Pensacola. We'll see you next week. Good night.